Thank you, Rishi, for inviting me to this IC.
Can you hear me?
Today
Can
we
you
will
hear him?
discuss what is troubling your patient.
Sir.
It's
Allergy,
perfect.
infection, dryness, or a combination of these. Rishi, since I'm not with you, I request you to change the slide whenever I say next. Next. My financial disclosures are obviously none. Next. So it's easy when the features are classical, like in classical allergy that you can see here, giant papillae on the palpebral conjunctiva. The limbus is studded with the horner trantus dots and the limbal variety of spring cuttard that you can see in the other pictures. So when it's classical, there is no difficulty in distinguishing that this is pure allergy. Next. Also in pure conjunctival infection, the pink slide that I've selected is from my father's collection of 50 years ago to show that simple conjunctival infection or conjunctivitis has not changed in appearance, in clinical appearance since my father's time. There's no ciliary flush, there is conjunctival congestion, mainly the fornices and far away from the limbus. You can have mucopurulent discharge, as you can see in the other slide, and it could be part of an epidemic with bilateral involvement. So pure infection, again, a no-brainer. Next. Also pure dry eye patients, the computer vision programmer with infrequent blinking that you can see, the meibomitis looking obvious, pompous blepharitis with the dandruff or scales that you can see. And if you do any test like the Sherman's test, it comes very little amount of wetting, classical rose Bengal staining, or a reduced breakup time. So these are classical dry eyes. You don't have to wait till you see filamentary keratitis to diagnose a dry eye. So this is again a classical dry eye. Next. Let's what about mixed issues? What about a patient with allergy and dry eye? Is it possible? Yes, of course it is possible. How do you diagnose it? Use your ears first, not your eyes. So careful history. Patients of allergy will complain of itching sensation. Is the patient also complaining of a sense of burning sensation or a sandy feeling or a foreign body sensation along with the itching? Perk up your ears. It could be a dry eye in addition. How do you confirm this? Simple. Just do a therapeutic trial, add preservative-free lubricants to the allergy treatment. Is the patient significantly better? If so, that means your diagnosis of a mixed allergy plus dry eye was correct. Next. Let's talk about conjunctival infection a little bit. Most cases are viral, don't need heavy topical antibiotics. Just because the medical rep came to you and promoted oxyfloxacin or higher strength catafloxacin, you don't have to use it on poor unsuspecting conjunctivitis. A simple lubricant will be enough. Or if you must give something, you can use something as simple as chloramphenicol or polymyxin or the lowest possible antibiotics. And don't overtreat. If you treat it for 4 to 7 days or 10 days maximum, it will improve. If it is not improved, it is not a bacterial conjunctivitis. If it is worsened after initial improvement, suspect conjunctivitis medicamentosa. Immediately stop the antibiotic drops. No tapering, and replace with non-preserved lubricants. Frequent use. Patient should feel better within 48 hours. If so, then you are dealing with the medicamentosa and you can gradually add surface acting steroids to the lubricants. Next. So beware of this. The classical picture of a keratitis or a conjunctivitis medicamentosa. If cornea is involved, keratitis. If not, it's conjunctivitis. You get a foggy, chemotic conjunctiva. And of course, plenty of symptoms and signs. Next. So symptoms will be initial, typical, this is initial improvement in the original condition. Perhaps there was a conjunctivitis, it improved with your antibiotic drops. Then there was a deterioration, despite your increasing the antibiotic drops. Then worsened ocular pain, stinging, burning, photophobia, and in signs you saw fogginess of the lids, fogginess of the conjunctiva, some blurred vision. If it is medicamentosa of the cornea, keratitis medicamentosa, then you could see SPKs or even epithelial defects could be there, and dilated vessels like you see in the picture on the right of long standing, and a follicular type of conjunctival congestion could be there. Sometimes you could even see pseudodendrites. So beware of this condition and to diagnose it. Next. So dry eye plus infection can most certainly coexist. It's not uncommon. Don't overdo the topical antibiotic treatment, otherwise you push him into medicamentosa. So again, add topical antibiotics, but remember that topical antibiotics, especially aminoglycosides like gentamicin or tobramycin, are toxic to the surface in dry eye and can worsen the dry eye. Hence, treat aggressively for a week or so and then abruptly stop the antibiotics, but don't forget to continue the lubricants. Next. What about allergy and infection? Of course, they can coexist. Remember, most of your allergy patients are children. They love playing with animals who are dirty. They love playing with other children who are sometimes even dirtier. And they often rub their eyes with dirty fingers. So suspect a coexisting infection if the parent tells you on the phone that the eye discharge is different. Call the patient in and look for coexisting infection besides papillae. If the rest of the conjunctiva is also looking red, then a short course of frequent topical antibiotics is required. But let the allergy treatment continue. Don't stop. Avoid aggressive steroid therapy in diagnostic dilemmas. I told you things can coexist. So please don't use steroids because they suppress all symptoms, but they might even cause a fungal infection and even a fungal corneal abscess sometimes. And avoid shotgun therapy with multiple anti-infective agents. So if it's a red eye, you add antifungal, antiviral, antibiotics, steroids, the works. These are a sure recipe for conjunctivitis medicamentosa. Next. To conclude, allergy plus dry eye or infection plus dry eye or allergy plus infection can most certainly coexist. Learn to recognize and treat these. Avoid telephonic diagnosis and treatment of chronic dry eye or allergy patients on the phone. Don't overdo anti-infective treatment. You can cause medicamentosa. Do not taper topical antibiotics and beware of conjunctivitis or keratitis medicamentosa. Next. I hope I have removed some of your cobwebs and made things a little clearer. The things can coexist. No shotgun therapy, no overdoing steroids, and avoid medicamentosa. Thank you so much for your attention.